So dear friends, we are going to continue from where we left in the previous PPT. We left in the optic nerve. We independently understood what is light reflex. Then we took up optic nerve and analyzed it and understood if there is a lesion in the optic nerve, what is going to happen. Now the next level, next to the optic nerve, is the optic chiasma. The optic chiasma is a very important uh, uh, like a decussation of the optic nerves of both sides. The nasal fibers are going to decussate. Nasal fibers are going to decussate. So can you see the nasal fibers of this nerve is going to go over to the opposite side. Okay. And the nasal fibers of this side is going to go over to the opposite side. So decussation is going to happen. But if you see the temporal fibers, they are going to go on the same side. They are not going to decussate. The temporal fibers are not going to decussate. So this is the optic nerve of either side. Optic nerve of either side in the chiasma. The chiasma is located in a very, very important critical area of the brain. The chiasma is sitting right over the diaphragma cellae, and in the diaphragma cellae, below the diaphragma cellae, in the sella turcica, the pituitary gland is situated. Can you see the pituitary gland? This is the sella turcica, and this is the pituitary gland. And the chiasma is situated right on the top of it. Right on the top of it, my chiasma is situated. Similarly, my chiasma on either side is hugged by my internal carotids. My internal carotids on either side is going to be very close to my chiasma. So if at all my pituitary becomes a tumor develops in the pituitary, my optic chiasma in the midline is going to be affected. If my internal carotid is going to develop an aneurysm, the optic chiasma in the lateral aspect is going to get affected. So this is the two possibilities of a chiasmal lesion. So in this diagram, we see the chiasma here. This is the chiasma, and the chiasma is affected by a lesion right on the midline. So midline, what is the lesion? The lesion is pituitary, basically pituitary. You remember pituitary alone. There are others. Don't forget about them. They become very confusing. So think about the pituitary. So if my pituitary fibers are going to become like pituitary is going to develop a tumor, and that tumor is going to breach the diaphragma cellae and come up out of the sella turcica. It is going to press on my chiasma in the midline. If my chiasma, the midline is going to be pressed, then what is the fibers which are affected? The nasal decussating fibers are going to be pressed. Yes or no? We said the temporal fibers are going to go straight away. They are not going to be affected. So the nasal fibers on both sides are affected. The nasal fibers on both sides here concentrate. It's a very important point. The nasal fibers of my both eye is going to see my temporal field. The field which is it going to see the temporal field. Okay. Similarly, the nasal fibers here is going to see my temporal field. Yes or no? This is my temporal field. So both my nasal fibers are going to see my temporal field. So when my temporal field is affected, I get a temporal hemianopia. Can you see? Temporal hemianopia. And it is temporal on both eyes. Both in this eye and in this eye, my temporal, whatever is seeing is white. Whatever is blind is black. So both the non-seeing areas are temporal. This is called a bitemporal hemianopia. So bitemporal hemianopia is a lesion which is usually asked in MCQ. The question will be very simple. Bitemporal hemianopia is caused because of a lesion in the optic chiasma. What is a common lesion? Pituitary tumor. Finished. That is all. Forget every other thing in this slide. Remember that point. Now in the same chiasma, we understood that in the sides of the chiasma, I can have a internal carotid artery. So we presume that I am hypertensive, chronic hypertensive, and my internal carotid artery has an aneurysm. So this aneurysm is going to press on my optic chiasma. Where is it going to press? It's going to press on either sides. What is there on the either side of the chiasma? My temporal fibers. So my temporal fibers are here. They are going to see what? My temporal fiber is going to see my nasal field. Nasal field. So my nasal field of vision is seen by my temporal fibers. So because of this, both eyes, my nasal field is cut off. My nasal field is cut off. And this kind of hemianopia is called binasal hemianopia. And this binasal hemianopia occurs in a case of chiasmal compression, which is happening from the sides. The best example is aneurysm of the internal carotid artery. Okay. Both are chiasma. Remember, even the previous slide is chiasma. This is also chiasma. But that chiasma is midline chiasma. This is lateral chiasma. Okay. Now, after the chiasma, what are we going to see? After the chiasma, so this nerve we have finished. Nerve we have finished. Then we have come to the chiasma. This chiasma we have finished. Now what do we have? We have the tract. Tract goes to where? It goes to the LGB. From the LGB, what happens? The radiation starts. And the radiation goes where? It goes to the cortex. So cortex, radiation, lateral geniculate body, optic tract, optic chiasma, optic nerve. So the optic nerve, optic chiasma, optic tract, lateral geniculate body, optic radiation, and visual cortex. This is the sequence of events, sequence of fibers which are seen in a case of visual pathway. If you dissect the visual pathway, this is how the multiple levels which we are going to see. So now we have to see what the tract will cause. If a lesion to the tract, what will happen? What a tract lesion to the lateral geniculate body will cause, what a lesion to the radiation will cause, and what a lesion to the visual cortex will cause. And interestingly, here there are 2 or 3 extra points. One point is the radiation is so very broad. Can you see the broad area? The main fibers are the dorsal fibers which go through the parietal lobe. Okay. Then there is a central bundle which goes through the temporal lobe. But certain fibers in the temporal lobe take a Meyer's loop. This is called a Meyer's loop. So radiation has 2 groups of fibers. One group of fibers which is dorsal goes through the parietal lobe, and the other fibers go through the temporal lobe. And in the temporal lobe, the fibers take because the uncus of the temporal lobe is situated in such a fashion, they take a circuitous loop-like route, and that loop route is called the Meyer's loop. The Meyer's loop, remember? Meyer's loop. And similarly, in the visual cortex, I told you, area 17 is the primary visual area. But next to 17, we have the 18, which is visual area, and 19, area 18 and 19. So area 17 is on either side of the calcarine sulcus. So it is called the calcarine cortex. So calcarine cortex is area 17, which is the primary reception area. Then area 18 and 19 are secondary association areas. So this is the basic anatomy overview of the posterior part of the visual pathway, which will be useful in our next PPT when we see lesions of these levels. Thank you.